Welcome to Sagely Speaking with Mary Bono, the esteemed former Congresswoman known for her insightful perspectives and vast experience. Prepare to be engaged in thought-provoking conversations with influential personalities, exploring a wide range of topics, from social issues, politics, and policy, to personal development, shedding light on important issues that impact our society. Now, here's Mary.
Hello, and before we begin this week's episode, I want to take a moment to express my deepest gratitude to our sponsors, Zomad and Map to Action. You can find out more about them on our website, sagelyspeaking.com. And thank you to our Sagely Steward listener, Julie, who created a custom sweatshirt for me with a Sagely Speaking logo on it. Sent it to me. Very sweet of you, Julie. Thank you. And now, please welcome our guest today, and that is Rich Hamburg. Rich and I started working together about a decade or so ago. Hard to believe. He's a leader in advocacy and the policy space. He is the executive director at the Safe States Alliance, which is located in Washington, D.C. Rich joined Safe States in 2018. And beyond that, he's got an extensive and impressive bio, but I'm going to let him tell you all about that. I wanted to bring him on to talk to us about how the opioid space, the fentanyl problems, all of these things we talk about all the time, how they fit into his world, and what does that advocacy look like and his expertise. So, Rich, welcome. We appreciate you being here.
Thanks, Mary. My pleasure. Always good to get together with you.
Indeed, it is. So you have experience in so many different areas beyond opioids and fentanyl. I've always been impressed by the work you did with being anti-tobacco and with Heart Association. Can you talk about your experiences there and how they translate now into the public health space? And I know we could talk COVID, but specifically with opioids and the crisis going on today.
Sure. Well, my background is, purely public policy and public health space. Been an advocate at the federal level first at the state level for several years, and then at the federal level for 35 plus years. And, this all ties together. It's all about, at the end of the day, public health, and public health being chronically underfunded, and public health having to, scratch its way to the table, no matter what the issues are. And my background includes, everything for advocating for cardiovascular health, for public access to defibrillation, tobacco control, funding and preparedness related to emergency preparedness, pandemic preparedness, and in more recent years around injury and violence prevention. And of course, injury and violence prevention includes fighting the opioid epidemic and the fentanyl epidemic. So, that's what I've devoted my career to. And, get to work with people like Mary and lots of other public health experts in the field. And there's just so much overlap on the issues that I've worked with and that I continue to work with currently.
Yeah, once you understand advocacy and how it works, it's probably usually a pretty good blueprint. I don't know, in today's environment where things are a little bit challenging, I guess, to put it lightly, perhaps things are a little bit different. But you talk about public health being underfunded. Why is that?
Well, it's been relatively recently that the nation has begun to invest in prevention. We've always had significant investments in treatment and medical care. And, over the years, there's been more of a realization, as the old commercial goes, you can pay me now or pay me later, and investing in prevention, on something like use of tobacco products. That's just going to save millions of lives and billions of dollars over time. And it's been, I'd say, just the last couple of decades where there's been a focus on prevention, certainly with the debate around the Affordable Care Act 10 or 12 years ago. One of the happiest days of my life, I think, when I opened up the paper or turned on the TV and saw that prevention provisions were going to be one of the three major parts of reform, certainly quality of care and coverage of care. But, it was dramatic to hear that prevention and a national prevention fund would be part of the debate. So it's been slow in coming, but I think there's more and more of an understanding, certainly in a bipartisan fashion, or nonpartisan fashion, I should say, that spend money in preventing illnesses, or in my case, when I'm working on injury and violence prevention, everything is preventable. That's why we generally don't even refer to accident. It's preventable crashes, preventable fill in the blanks along the spectrum of injury and violence prevention. drownings, burnings, shootings, it's all in some way, shape, or form preventable.
That's interesting you say that, because every accident I had, I didn't feel like it was preventable. I've learned I'm just a klutz. But in any event, your expertise with tobacco cessation and what we've done, why is there such a disconnect between obvious needs for public health? And I'm looking right at you, opioid manufacturers. Why does it take so long for the connection to happen between either a current crisis or a soon-to-be crisis and policymakers realizing that they need to step up and pay attention to this?
Well, historically, there are certainly far more good players in various industries than bad players. Sometimes it takes time for information to become public. It takes time for public health professionals to realize steps that need to be taken. For tobacco use, it was decades and decades of the tobacco industry hiding kind of the obvious fact that tobacco products had deadly carcinogens and that nicotine was addictive. Took until 1994 in that famous congressional hearing room where I was seated somewhere in there watching the seventh tobacco industry executives raise their hand and say tobacco wasn't addictive. So it took a lot of good lawyers and a lot of good research and some whistleblowers to really turn things around in both the tobacco situation and on the opioid front. And, I should also note that after there were settlements in the tobacco case starting in 1998 with historic tobacco settlement, tons of money has been allocated or has been generated from the tobacco companies to state and local governments, about $25 billion every year. There's a group that I've worked with over the decades called the Campaign for Tobacco-Free Kids. And each year for 25 years, they put a report out showing just how little of the money that was garnered from payments from bad deeds done to addict America's children. Only in 2024, 2.8% of that money is being invested in tobacco prevention and cessation programs, which is less than a quarter of what the CDC recommends. On the opioid front, those multiple settlements with various companies now, state and local governments are receiving $1.5 billion a year, $50 billion expected over the next 20 years. I believe more is being spent on public health interventions, purchasing naloxone, overdose reversal medication, rehab facilities, covering care for the uninsured. But I believe it's still a relatively small percentage of the money that was generated. So the best thing that can ever be done is to increase investments in wellness and prevention, and it'll pay dividends down the road. There is a return on investment economically, and there's a return on investment in saving lives and reducing the effects of the diseases.
The tobacco settlement funds, everybody knows they were squandered and went to fixing potholes rather than the original intention. And we're trying to prevent that with opioid settlement dollars. A bunch of leaders in that space who are trying to put in guardrails and make sure that people are held accountable, the folks who are actually spending the money, to make sure they go to proven solutions to the problem. Full disclosure, so my mother was a smoker and she had COPD by the end of her life, so I was never a big friend of tobacco, for sure, but you've talked to me about the declining numbers, especially with teens using tobacco. However, now they've switched to vaping. And I think the alarming thing about vaping is most of what the kids use are these illegal disposable vape products that are made in China, and they're deliberately designed to be targeted to our kids with youth enticing flavors like, tutti frutti, you name it, whatever is sweet. And so here we are again. So yes, tobacco products down, but vape products coming from China way up. Is that on your radar?
It's Groundhog Day. It took many decades to reverse the trends of tobacco use. When I was growing up in the 60s, the rates were well into the 40s. So almost 1 in 2 adults use tobacco products, and tobacco use now among adults is down to 11.5% and less than 2% among children. So you would think that this is a great day for America and America's health. And then you're like, oh, wait a minute. These vaping products are multiplying and multiplying. And as Mary, as you say, they're being targeted to kids and candy flavors. I grew up with marketing of candy cigarettes and no one gave it a second thought. Hey, that's cute. Look at the little 6-year-old smoking or fake smoking a cigarette. And two things. One, unfortunately, now 4.5% of adults, doesn't sound like a big number, but it's growing exponentially, are using various forms of electronic cigarettes, including vaping, with the rate now over 10% among those 18 to 24. So, and there's so many products and hard to keep track of it. A famous commercial that those of a certain age may remember, when there was equal time given between the tobacco industry and public health advocates. There was an individual, his name was Tony Schwartz, who produced all of these commercials. And the most famous commercial was of two children dressed up as their parents in the attic in, top coat and hat and a fur or a heavy coat for, there's a boy and a girl. And the tagline was, kids imitate their parents. And then the next scene was kids smoking. So it's all about our kids. It's putting as many barriers as possible to prevent the use of dangerous products. And now we're having the same worries around opioids and heroin and fentanyl. And as I said, Groundhog Day. And we can never take our eyes off the prize, off the ball, because there's always going to be another product for various reasons that are going to, begin to addict adults and children. So, it's our job as public health advocates to learn from our prior lessons and continue to do whatever we can to educate the public about the dangers of certain products.
Rich, I want to go back a little bit to the illegal Chinese vape products, because I know it would be great if adults didn't choose to vape. But at the same time, many of them are stepping down from cigarettes and moving to legal vapes that are regulated and that are, what's in them. But the problem with what is happening to our kids is they're getting these illegal products from China. And oh, by the way, the Chinese don't even allow them to be sold to their own people in China. They're so dangerous. We don't know what's in them. We don't know the levels of nicotine. And yet they're exported here, and kids can get them the same way they can get opioids through the internet, through social media channels. And I know that the FDA is trying to do a lot, but at the same time, it seems they might be all talk and not enough action. Or is the FDA stepping up on these illegal, dangerous products coming from China?
Yeah, I think that there have been some real strides made through federal agencies like the FDA. The Food and Drug Administration has only had the authority over tobacco products since 2009 law. So we're talking a dozen years that these deadly products were exempted in prior legislation from the 20s and the 30s, when there weren't public health advocates, but there were tobacco industry lobbyists. And you'd be just shocked to see the kind of language that were in these bills when these laws, when no one was paying attention. So the FDA has only had 12 years, and prior to that, the tobacco settlement. And so it takes a long period of time to turn things around. And vaping products and electronic cigarettes, they've been around for 35 years. There's a picture I have somewhere my wife took when I was a young lobbyist, and we received a packet of Premier cigarettes. It was the original. I think it was R.J. Reynolds was trying to market them. And a number of court actions kind of delayed that. And then no one ever heard about it for years. And suddenly, when tobacco use went down substantially and various aspects of the industry had to figure out a way to continue to make money, they kind of reinvented themselves with these reduced risk products. Now, reduced risk is an important concept, and I can't say I'm no longer an expert on it, but the concept is it better to have individuals step down, as you said, to use lower risk products? There was a whole debate around smokeless tobacco. Okay, great. Less people die, but they die hideously from horrible things happening to their face and their head. It's a debate for others to have, whether or not these products are dangerous enough that the only possible solution is not to use them. And there are a number of ex-smokers who did step down and use some of these other products. The big but is, from the numbers I gave earlier, now they're targeting kids. They'll say they're not recruiting new smokers, but they said they weren't recruiting new smokers 30, 40 years ago. And the marketing, the advertising restrictions put on the industry from that tobacco settlement are substantial. And for anyone around in adulthood before that, 1 out of every 2 billboards was a tobacco billboard. Every magazine, advertisements, minority communities who no one else would invest in, the tobacco companies would come in and invest in entertainment and every possible way they could to win the hearts and minds of the residents of particular areas. So got to keep the eye on the use of these vaping products, and kind of a similar, hopefully the FDA slowly but surely will take actions similar to the ones that took over tobacco products, and hopefully a lot quicker than happened, with tobacco. That took decades, and I'm hoping the public health response, and I'm confident that it is quicker than it was. And, groups like the American Cancer Society, American Lung Association, American Heart Association, who I work with for close to 20 years, and many other public health organizations are working closely with agencies like the Food and Drug Administration to make sure that what happened years ago doesn't happen again to our children.
Well, to your point on effective marketing and advertising, I still think the Marlboro Man was a handsome guy. So that worked for me. But, moving on a little bit back to, well, first of all, the FDA. You and I work a lot on FDA issues, trying to get them to be faster on some things or listen to our message. And sometimes I'm a critic and sometimes I'm their greatest fan. So I do believe they've got a lot on their plate. And this is where your advocacy is effective, right? Is how do you ratchet up something that's more important? I think we've come a long way with the opioid issue. I remember 20 years ago, 15 years ago, the FDA was just asleep at the switch. And now I appreciate their participation and partnership on a lot that we do. Something, again, you talk about that resonates with me. And we've talked about heart association experience and the defibrillators, the easy public access to that. Wouldn't it be a no-brainer to have naloxone, the overdose reversal medication? Wouldn't it be a pretty simple policy solution to make sure that naloxone is easily accessible for any bystander should they need it?
Oh, yeah, 100%. And, I ad nauseum with our partners in crime and public health, almost to the point of rolling their eyes when I talk about public access to defibrillation and the similarities to public access to naloxone. So you could make a chart, go down, make a list, go down the list that defibrillation was only available in a hospital setting, naloxone only available in a hospital setting, and then available to EMS, and not even all EMS, advanced EMS for defibrillators, and then same thing on naloxone, and then hey, who are the first responders at most of these cases? It's public safety. All right, so why shouldn't the fire and police have it? And so over time, public access to defibrillation, targeted placement of defibrillators. There's not a public building in America that you walk into now that doesn't have a defibrillator on the wall. Training of responders, coordinating with EMS. So you do want to coordinate with the EMS system, maintenance and testing of those devices, and then Good Samaritan protections, limited civil liability or qualified immunity. So now to naloxone, same thing. What are the goals? Increasing access to naloxone, removing obstacles to the use, providing standing orders so that consumers can procure naloxone with or without a prescription. And, now it's available in supermarkets. The idea of potentially co-prescribing with opioids. You provide an opioid prescription, you should provide a naloxone prescription. Access in schools, that's become a big issue, a group that Mary and I participate in, Collaborative for Effective Prescription Opioid Policies, has had several expert convenings, specifically on school policies. And then same thing, Good Samaritan protections. And the interesting part about Good Samaritan protections is at the beginning of the policy initiatives around defibrillation, and I think similar with naloxone, there was a worry about being sued for providing life-saving services. In the case of defibrillation, it's kind of ridiculous because if you're not defibrillated, you're likely going to die of the cardiac arrest. So, what kind of harm could you do? And so early on, it was convincing people and passing Good Samaritan laws that earlier on were put in place in almost all 50 states around CPR training and first aid, and now AEDs. Over time, I'm no lawyer, but I guess the general concept is, okay, first it was being worried that you'd be sued if you use a defibrillator. Where things really changed were suddenly individuals and companies were being sued for not having one. Hey, if this is a life-saving device and you don't have it, then perhaps you should be liable for not providing it. It's got to be the same case with naloxone. If it saves lives, then whatever the places are that you're highly likely to have overdoses, then you're doing a disservice for not providing, and you may be liable for not providing access to life-saving naloxone.
And I think it's always important to note that using naloxone when it might not have been called for, actually, might have sort of misunderstood what was happening to the person, the victim. And if you administer naloxone, there's no harm. You're not going to harm somebody by giving them the intranasal Narcan spray. So I think it's critically important to talk about this. Another thing on the horizon is a lot of conversations about trying to encourage folks to talk to their doctor about a non-opioid alternative for their pain management. A new concept, and I think people are afraid. Look, we all think I've got, a prescription for some opioid that I'm going to hang on to just in case I need it somewhere down the road. I understand that. I've had pain, I've had surgeries, so I get that mentality. But now to switch people back to the concept that something that is non-addictive but could be just as effective, is Safe States engaging on that?
Yeah, we certainly, and others in the public health field, support the use of non-opioid alternatives, where they're effective. And I think it's after the last decade or so where first there was prescribing of these pain medications, and then overprescribing. And then we've all seen from the various cases, salespeople for the various companies being paid to not only prescribe more opioids, but pills with stronger and stronger and stronger pills. And it's still an effective means, for pain killing, but for certain people. And are there alternatives outside of prescribing opioids? And there certainly are. So, I would like to see more research and better understanding of ways to address pain. And I'm sure tens of millions of Americans have chronic pain. So, there's two things we're dealing with here. It's kind of the acute event and there's chronic pain. The acute event, the idea of having your teeth pulled and the doctor giving you 30 pills is fairly insane. 90% of individuals who come back from having a post-root canal or post-teeth being pulled might use one pill. Maybe they need it for 2 days. And, we had millions and millions of bathrooms with leftover opioids, and that became a crisis. And, thus we've had a long discussions around effective disposal of the products. So it's complex. And the opioid crisis, what caused it is complex, and the public health response is complex. It's not just providing Narcan, naloxone. It's not just restricting availability of opioids for those who might not need it, at least in the doses that are being prescribed. But there's electronic medical portion of this. There's education of doctors. It's a broad spectrum. And I found over my career that, there are very few simple magic bullets to addressing a health crisis, particularly a pandemic level crisis. So there's a lot of things that we need to be doing, and that includes finding alternatives to the use of opioids.
Rich, you mentioned collaborative for effective prescription opioid policies, which you and I began together with a group of co-conveners. And I'm very proud of the work we've done because we've looked for that sweet spot in policy. We've recognized that there is a need and a time and a place for opioids in the pain management space. And we've tried very hard to make sure we respect the doctor-patient relationship and the prescribing that the doctor should know best. But we've also done a great job here of ringing the bell and saying, let's wake up to this problem and then find the solutions. And I'm proud of that work because I know that we never want the pendulum to swing too far. We don't want to deny people in pain the medication that their doctor prescribes. Yeah, but we want to keep it out of the hands of our kids.
Yeah,
that should be fairly simple.
Yeah, absolutely. And the whole CPOP, the collaborative, the reason for it, and there's some pushback from some circles that it brings everyone to the table. And I've also found in the work that I've done that just about everyone needs to be around the table. So that collaborative, includes public health, medical specialties, family members, patients, but also companies and distributors and pharmacies. You need to work together and you need to talk to each other. Work that I've done and others have done, not to get deeply into the crisis of gun violence, but in recent years, been some good collaboration between gun owners and the public health community. We had collaboration leading up to the tobacco settlement with tobacco growers. We had collaboration with the defibrillator manufacturers in the work that we did. So, you hold to your ethical standards and you know what you're trying to do, but you can't do it. You can't do it in a vacuum. So I've really enjoyed the past 8 or 10 years of the work on the collaborative, because, it always has various sectors around the table. As they say, health in all policies, and upstream approaches to public health has become, kind of a key rallying call in our community. And that means you can't operate in a vacuum. And, injuries and violence prevention, that's got to be tied to working with safe housing and safe transportation and schools. And the more that individuals work together, the work that I do now is also across a broad spectrum. You have unintentional injuries, you have drownings, you have burnings, you have senior falls, you have the opioid crisis, you have sexual violence, you have gun violence. There's just so much that an organization like Safe States is trying to accomplish. And we do find that it's important to do convening, to chair or to organize convenings of experts from various sectors. When people are listening to each other, trying to come up with joint solutions, I've always found that we'll make more progress at the end of the day.
I couldn't agree with you more. It has nothing to do with this topic today, but I saw this in action. I created a national monument legislatively, which is the way environmental policy ought to be done. And what I did was I got my environmentalists to sit down with my developers, my ranchers, the people who are generally on both sides, sort of Hatfields and McCoys. And we sat down around a table and we worked it out. And to this day, over 20 years later, it's still being heralded as the right way to do policy. So I applaud you. And for the record, you could probably tell Rich and I are on different sides of the aisle, although I'm kind of smack dab in the center of the middle aisle these days. But I love that spirit. But I told you before I lose you and we close, I told you I was going to ask you this. Okay, so suddenly you're granted all the money in the world. What would you do? What would your top 3 things be to solve, let's stick with the fentanyl poisoning crisis. Fentanyl is killing kids the first time they try a drug. And again, the answers are very complex, but I've just given you all the money you could ever dream of. What would Rich Hamburg want to do with that money to save kids?
Well, first off, Safe States Alliance, nonpartisan. I'll put that out
We're
there.
here to prove that.
And I think that my answer will still be a kind of a public health answer, and hopefully not too wonky, which is a multi-pronged approach. Multi-sector approach. If you had to number them, one, a multi-sector approach to the synthetic opioid pandemic. As public health advocates, the second important thing is communications, monitoring and analyzing communication trends, building health department capacity, cooperation between public health, public safety, providers, health systems, and importantly, in the communications area, raising public awareness and reducing stigma. Reducing stigma is incredibly important. And then public health, we're data people. So providing stronger data to inform where the focus should be related to use of naloxone, decreasing stigma, addressing, the fentanyl crisis. More data leads to better solutions and hopefully quicker response to whatever epidemic we're talking about. But in the area of fentanyl, we've seen that horrors of more than 100,000 deaths each year, 100 times more potent than morphine, 50 times more potent than heroin. So, we got to get going on this because those numbers could still go up dramatically. But from a public health person's perspective, it's all about communications, information, data, and reducing stigma.
Thank you. Very thoughtful answers. But for the record, Rich, I think that was more than 3 things. And you kind of did that when you're asked the genie, you can have 3 wishes from the genie in the lamp. What's your first wish for 1,000,000 wishes? You might have just done that effectively, but nice job.
I've seen members of Congress on the floor with, I remember when he was a state legislator, Jerry Nadler, I think it was Jerry, he used to go up there and say, I've got 1 point to make with, 4 subsections. So there are 3 points with a lot of subsections.
Well, it's effective, right? I do want to thank you, though, Rich, for your work, for the way in which you do it. Love working with you. So when I thank you for joining Sagely Speaking, but can you share with our listeners a way to contact you or find Safe States Alliance, your website?
Yes. Well, first of all, www.safestates.org. And just provide a quick background. We're a national public health organization with over 500 members, injury and violence prevention professionals in health departments and hospitals and universities. And we're dedicated to strengthening the practice of injury and violence prevention. We provide training, professional development, enhancing capacity of public health agencies to conduct injury and violence prevention programs, and support health policies designed to advance the field. So we feel that it's important to collaborate with other national organizations, other national leaders, federal agencies to advocate for public policies. And as I said earlier, to convene leaders in the field. So we have tons of information on our website, www.safestates.org. I urge you to go visit.
Thank you again, Rich. Thank you very much. And a special thank you to our listeners. I'm Mary Bono, and I welcome your feedback at hello@sagelyspeaking.com. Again, hello@sagelyspeaking.com. I look forward to our getting together again soon with more Sagely Speaking.
Thank you for joining us today on Sagely Speaking with Mary Bono. Remember, wisdom is a journey, not a destination. For more insights, visit our website at sagelyspeaking.com.